So hello everyone, officially we're starting with this TBPPM webinar on a really great topic. We're hosting today with ShiftTB, which is a virtual center focused on social science research and innovation to address the global TB epidemic. And our topic is today about how to ensure that quality TB care is people-centered TB care. We are recording. We are live also on our YouTube channel, and this recording and all the presentations will be made available online afterwards. You will see that we have a Q&A button where you can post any question at any time during the webinar. Our panelists will try to respond to you directly on your specific questions, and several of your questions will be picked up for the panel discussion today. Also, we are trying something new today at the end. We will keep this webinar link open for an additional half hour for you to exchange thoughts. The recording will be stopped and the webinar is officially over, but anyone who wants to stay to talk or express their opinions or ideas can be moved onto the panel, which is an opportunity for you to talk to each other. We're trying this out. Let's see how it works. More on this at the end and after the panel discussion. But on to today's topics: how to ensure that quality TB care is people-centered care. We have a great lineup of speakers, and we know that communities, TB survivors, and people of TB are increasingly recognized as important voices for high-quality interventions, yet the design and planning of TB programs still focuses often mostly on coverage and efficiency over people-centeredness. And social science data on healthcare seeking, social determinants, and the needs and preferences of program users, the people, as well as the implementers, the providers, are often missed. This is what our fabulous speakers will be talking about today. So I'm proud to introduce you to our great panelists. First of all, we have with us Handa Amgalan. She is a humanitarian and a development professional from Mongolia with global experiences in policy analysis and research, program evaluation, and strategic communication. She works at the International Rescue Committee. Handa also has recently authored a creative nonfiction book, Stigmatized, which is an absolute must read. It's a great, great book where she talks about her battle with tuberculosis, the associated stigma, and how her various identities inspired her to combine storytelling with activism. And she will share her thoughts today about person-centered care. Then we have with us Jeremiah Chikowore, a senior research specialist in the Human Sciences Research Council in South Africa. Jeremiah is trained in sociology and public health, and his work applies social science approaches to a range of health issues using a complexity and intersectionality lens. Jeremiah is a founder and a director of ShiftTB. And we're really happy that today he will be giving us examples from Malawi and South Africa, looking at the people-centered care and patient agency. Then with us is Andrew Mcdowell. He's an assistant professor in the Department of Anthropology at Tulane University. He has a PhD in sociocultural anthropology from Harvard University. His research interests focus on care, contagion, pharmaceuticals, diagnosis, and inequality in North and Western Indian social worlds entangled with tuberculosis. Andy had to evacuate his home in New Orleans due to the storm, and we're very happy that he has been able to send us a recording, which we will be watching, and he's with us for the Q&A. So he'll be talking about treating physicians' insights related to patient needs and quality care. And then with us is Jody Buffa, a research fellow at the Center for Rural Health at the University of KwaZulu-Natal in Durban, and works also in the division in epidemiology and biostatistics at Stellenbosch University in Cape Town in South Africa. She has expertise in community-based research and epidemiology with a focus on TB and TB-HIV, and she'll talk about the experience of client actors as a proxy of a patient voice. Really happy to hear her research. And finally, I'm pleased to introduce you to our moderator of the panel discussion, Vijaya Sri Jelapa. She's a medical doctor specialized in public health, and she has a fellowship in HIV medicine. Her PhD focused on strategies to optimize the involvement of private practitioners in TB in India, and she's currently working as a consultant at the premier policy think tank in India. She also had the steering committee of the TBPPM India chapter. She will moderate the panel discussion, and please, any questions at any time, post them into the Q&A and we will have some responses for you. With that, I will be quiet, and I'm really pleased to pass on the microphone to our excellent speakers, and you will see me after the panel discussion. Hanna, the floor is yours.
Thank you so much, Petra. Hi, everyone. First of all, thank you so much for having me on this panel discussion alongside many reputable TB researchers and experts. I'm very grateful. And today I'll be participating in this panel from the perspective of a former TB patient and current TB survivor and advocate. When I was 15 years old, I was diagnosed with pulmonary tuberculosis, which had created quite a large cavity in my left lung. Consequently, I was hospitalized for 2 months in a local health facility in Mongolia, and I went through a 6-month-long TB treatment process. And before I jump into the main topic around person-centered care, I wanted to share a brief story. When I was, after I was first diagnosed, my mom and I visited a local health TB facility to be hospitalized. And the doctor handed me a patient logbook where she summarized my TB diagnosis. When we exited that office, I opened that logbook to see what this diagnosis was about. And I was really shocked because there was only one letter that summarized my entire diagnosis. I grew very curious and I asked my mom why there was only one S letter there. She explains to me that S stands for Surye, which means tuberculosis in Mongolian language. And she explained to me, this is how the medical health system was protecting patients from potential bully, discrimination, and stigmatization attached to tuberculosis, just in case my patient logbook gets lost or if someone accidentally looks at it. For a 15-year-old girl at the time, I thought the healthcare system was very thoughtful that it was protecting me from potential stigmatization by only showcasing the first letter of the full name. But later on, I realized that as I educated myself more, as I became more informed advocate, I realized that actually the medical professionals, the medical sector had accepted the fact that tuberculosis carries stigma, and they had actually applied it to me by encouraging me to be silent about my story. And that's what I thought needed to change. But at the time, that's how I first got acquainted with tuberculosis stigmatization. And when I stayed in the hospital for 2 months, I started noticing what was happening and why the care needed to improve. And one of those issues was blame and shame culture toward TB patients, particularly with drug-resistant TB patients. Oftentimes, TB patients get blamed for being lazy, for not complying, or not taking their medications on time. It seems that there was a lack of understanding and empathy from the system, where there is a socio-economic broader context that needs to be considered before anything else, because it takes privilege to be able to pick up your TB medications or to take your medications for a long time. What if someone does not have public transportation? What if someone doesn't have a local health facility nearby? Because there are so many social health determinants that are causing TB patients into this trap. And that was a lack of understanding in the medical field. Another issue I noticed was there were lots of myths and misconceptions and lots of cultural norms that were interfering with scientific approaches. For example, I was told that eating dog meat, for example, could complement scientific approaches such as taking antibiotic treatment. And that sometimes confuses TB patients and causes economic challenges, for example. So from all these experiences as a former TB patient, I realized that TB care needs to be more humanized. TB care needs to be more dignified, where doctors, nurses, care providers need to treat TB patients with more empathy, with more understanding, and most importantly, with more human rights sensitivity. And that's exactly what quality care should be. centered on the patients, centered on their human rights, patient rights, centered on their empowerment and agency. And which is why I think quality care needs to start with training the trainer model, and not just on technical aspects of TB care delivery, but also on soft skills. We need more medical professionals, more care providers with empathy, understanding, to help patients, to empower them to use their stories, not hide their stories. And this is how I first became more passionate about advocating for these human-centered, humanized, dignified care towards TB patients. And with my book, one of my main goals is to really share my stories, to advocate exactly for more investment into empowering survivors. I really hope that one day every hospital has a committee, task force that consists of the patients and survivors to really advocate for less, for treatments with less duration, with more human-centered care. And that's why I joined TB advocacy and wrote my story. And I'm very excited to be part of this panel today and to have been able to share my story. So for me, quality TB care is a humanized and dignified TB care with empowerment and agency of the patients and survivors at the center of everything. Thank you.
Wonderful. Thank you so much, Hannah. Really, I mean, you're so well spoken about it and excellent points. Thank you so much for bringing that forward. I'm moving on to Jeremiah. Jeremiah, are you ready to present your slides and turn on your video? We can see your slides, Jeremiah, but they're still not on presentation mode.
All right. How is that, Petra?
That's much better. And do you want to turn on your video too, so that our audience can see you while you talk?
Thank you. Yeah.
Go ahead, Jeremiah. I will do it.
Okay. Okay. Thank you so much. Good afternoon, evening, and good night, everyone. And thank you to TBPPM Network and Shift TB for this opportunity. For some time, tuberculosis management in high burden and low and middle income countries placed a lot of emphasis on identifying and treating large numbers of patients at minimum cost to programs with the backing of free health services. While benefits were recorded, particularly in declines in incidence, limitations became salient within the HIV pandemic, and further, as the declines in incidence tend to be not at levels adequate to eradicate tuberculosis. Many people went and still go undiagnosed with disease in the community, and millions continue to die of a condition that should be treatable. Centering quality is thus crucial, and patient experience and patient-centered care are among the pillars of quality of care. I highlight observations from a study in Malawi, a low-income Central African country with high TB burdens, high ART coverage for HIV-positive TB patients, and high TB treatment success rate, but low diagnosis of expected TB patients. The study aims to generate insights of how to engage men in TB control, considering their TB epidemiological picture and relative absence from research and policy. Rowan Cornell holds that the interaction of various forces at multiple levels generates notions of masculinity. These notions vary, they are multiple and contradict within and across time and space. Ideal concepts commonly revolve around any of being rich, strong and healthy, heterosexual, white collar, provider, virile, in control / independent. Unattainable for many men, these qualities are nevertheless restressed through exclusionary action and rhetoric. Not achieving or demonstrating valued traits, that is failing health or no control over one's life, body, and responsibilities, for example, elicits stigma and stress. In turn, resistant actions may involve pursuing representations to extremes. Apologies. Reactions can include drinking or socializing, stretching the body limit during illness, immersing self in hard work as distraction or reaffirmation, relegating healthcare below family needs, or avoiding healthcare while looking to seem invincible. They can occur in intersection or in parallel. Now, which ones are expressed or how is context dependent? I'm just sharing some quotes here. One that illustrates how being busy, working in quote unquote, interferes with healthcare access despite the wish to be investigated, noting though that some could have underlying concerns about being investigated as indicated earlier. The other quote illustrates how men supposedly conceal illness or downplay symptoms. Some more quotes also illustrating how men explain the need to suppress symptoms based on their socially defined roles. And to the right, how seeking healthcare and being investigated conjures anxieties about possibly having something serious and about losing control of one's fate to the medical system. I'm showing some more quotes that are showing that the health system challenges that include drug equipment, shortages, poor patient-provider interactions, for example, being disrespectful or not upholding confidentiality, not explaining medications or acknowledging the patient's input, perceptions of favoritism, queuing for long times but leaving not served and hungry, feeling compelled into unexplained tests, all beget lack of trust within the healthcare system. Already with many reasons to be worried about attending health services, scrambling with women and children at health facilities calls to question men's role representation as provider and protector. Additionally, and understandably, demoralized staff shouting at patients could carry different meanings for men. Similarly, being taken through unexplained procedures can be a source of anxiety and of feelings that one is being treated like a minor. Now that was from Malawi. South Africa is also a high TB HIV burden country with high rates of undetected TB, low levels of healthcare engagement by symptomatic individuals, and high attrition along the care-seeking cascade. A third of those with TB symptoms are estimated to seek care first in the private sector. We carried out a study using the standardized patient approach or patient vectors to describe the quality of TB and TB HIV care management among private GPs, with a qualitative subcomponent assessing social and behavioral factors associated with quality of care. Ideal management was benchmarked against local and international guidelines. Out of 3 standardized patient care scenarios, the one presenting with classical TB symptoms was least ideally managed, being tested or referred appropriately only 43% of the times. And this pointed to widespread suboptimal implementation of appropriate procedures. We also noted a gap between GPs' knowledge and practices while interacting with standardized patients. Now, looking at GPs' manner of following guidelines or translating what they know into congruent practice, preliminary qualitative analysis suggests that they are making sense of altogether a lot of things, the socioeconomic and epidemiological profile of their immediate, but also their wider context of practice. Do the patient whom they see tend to expect medications? How are their means? What symptoms is a patient presenting with? What could this mean on their own? Then in the broader picture, what socioeconomic status is a particular patient portraying? how does a humane approach to managing patients and practicing fall in? If, say, patient happiness is a consideration, is immediate happiness the priority, or immediate happiness plus also longer-term satisfaction contingent on clinical outcomes? Into the mix are other interactional dynamics. For example, whether the patient is asking for antibiotics, or what and how much the patient is saying that is letting out or holding back, who the patient is being accompanied by, and what insights the person accompanying is giving. And some illustrative quotes. So just a passing note that several GPs seemed to deem the care that they gave to be humane and higher quality, with comfort, shorter queues and waiting times, especially when compared to the public sector. As is increasingly restated, there might be no quick fixes. For example, how to enable within the interaction of the provider and the patient and provider to collaboratively improve patient experience while tracking science provisions and guidelines. Some providers will take time to explain issues such as antibiotic resistance, which I believe could also be given greater and more relatable visibility within communities. Yet it is also easy for other providers to slide into paternalism, hence the need for ongoing capacitation of providers to have empathy, dedicate time to listening and explaining to the patient while having sensitivity to other dynamics, including gender nuances. Empowering patients to ensure the care they receive is acceptable to international standards will require strengthening social protection, equipping primary care facilities with minimum standards in terms of structure, drugs, equipment, and staffing. There is need to reflect more on what education and information can achieve outside structural interventions. Publicizing the need to be investigated when coughing can remain inadequate without understanding and addressing the structural reasons for patients to be tense and about healthcare. And for me, a closing matter is the practical question: whose standpoint is being privileged when patient needs are talked about? With that, I thank you and I acknowledge people I've worked with over the years and the funders. So thank you so much. Over to you, Petra.
Thank you, Jeremiah. That was really great to hear. And there are some excellent quotes from the provider side and points that you made, putting it in context. I'm sure that there's a lot more we can talk about. And we thank you so much for bringing that forward. Looking forward to questions from the audience on these and many issues. And now we're transitioning to the recorded video from Andy. And I'm looking forward to seeing that it works. Please let us know if the audio is not strong enough. Go ahead.
Hello, everyone. I'm Andrew Mcdowell, and it's really great to be with you today. I'm a social science researcher and medical anthropologist, and I've researched TB in India for the last 15 years. Much of my work has been in rural India, where I've accompanied patients in their search for diagnosis and treatment of TB. But today I want to focus on findings from two projects to improve the quality of TB care in Mumbai, and one on pediatric TB across India. In these projects, I've spent several thousand of hours in clinics and conversations with private sector general physicians and chest physicians who find themselves on the receiving end of global health interventions to improve the quality of diagnostic care. It's my position, as I've published in several papers, that these physicians are important allies in encouraging a more patient-centered TB care paradigm. They present, however, a double challenge that requires interventions center on two people, physician and patient. Physicians must be engaged as partners and generators of insight and knowledge about how to better care for patients in their context, and encouraged to center patients within their care paradigms themselves. Similarly, when we work with general physicians from their clinic, a startlingly obvious finding occurs. It's actually quite difficult to diagnose TB in a slum-based clinic in Mumbai, where patients want, like all of us, to be well with a minimal pharmaceutical intervention, minimal testing, and minimal cost. In this context, patient-centered care and high-quality care are often pulling in different directions. General physicians are frequently caught between a globally standard TB treatment algorithm, test for TB after 2 weeks of cough, that's considered the quality or standard of care, and attending to patients' pocketbooks, times, social worlds, willingness to risk a negative or inconclusive test result, as well as the ubiquity of cough in polluted global cities. Most negotiate this problem by initially using techniques drawn from the empirical treatment of fever and upper respiratory tract infections, and hoping that the patient has a common cold. From their clinics, the empirical use of pharmaceuticals manages patient illness, cost, and time precisely because physicians do not yet know that the cause of the illness is TB. From their perspective, quality of care for TB can only be assessed retrospectively, once a probable diagnosis has been reached, often after weeks of care that manages symptoms and finances. In a sample of 50 pediatricians who ever used Expert in 4 Indian cities, physicians reported ordering that test for one of 2 reasons: either because they were completely lost in their diagnostic workup, or because they were quite sure that the test would be positive. We also found that they very frequently treated children with a strong indication of TB empirically. This was a quick diagnosis and treatment, but is it quality of care? Perhaps, but perhaps not. This view from a private sector general physician's clinic shows 2 things. First, we must engage general practitioners as well as the patients who they treat, because they are aggregators. They see many more patients than most of us do in a day. In the Mumbai clinics that I observed, some would see between 50 and 150 patients every day. And it's their business to know what kind of treatment feels patient-centered to each of their patients, who many of them have known over a lifespan. It's also in their financial interest to join us in a project to improve quality of care and center it on patients. In a small pilot in Mumbai, we equipped 30 GPs of various qualifications with free of cost X-ray, CBC, Expert, and linkages to reliable and perhaps most crucially likable chest physician. TB case findings went from a 6-month average of 0 in this community to over 100 in just 3 months. We did this by learning what services they felt would allow them to better serve their patients and meet the needs their patients felt. In this case, this was a CBC and a chest X-ray. We then allowed them to follow up and order an Expert if the chest X-ray was TB suggestive, and further empowered them to work with the chest physician on adherence, side effect mitigation, and meeting other patient needs. By linking a TB-specific service, Expert, to those that generate important general diagnostic information, we improved quality of healthcare for both TB and in general. We made this quality improvement by helping physicians to center patients through free, high quality, and convenient diagnoses. In short, by centering patient priorities, we were able to improve care provided in these clinics. So, all of this work suggests that we cannot think of improving TB care and centering TB patients alone. We must improve care and center patients in general by taking questions of finance and convenience off the table. There are 2 existing ways to do this. One is through a universal healthcare model in which the state makes healthcare a public good, while the other makes basic health insurance available to all. Continued work on high quality and patient-centered TB care, when viewed from the physician's perspective, cannot bear fruit without a simultaneous effort to increase access and center patients and quality for all illnesses and all people. Of course, we're here to talk about TB, so I'll add that we must similarly recognize the utility of treating latent TB infections as another way to increase and make more high quality care for TB available. Indeed, by bundling it with active TB care in families and communities, will help us to avoid suffering, further centering the needs of communities and patients in our paradigm. We cannot, however, do this without a strong and patient-centered health system for all. So we have to think of these two things together. And I think I'll leave with that. My time is up, but I'm excited for more additional conversations with each of you and questions. I'll be available for some time in the chat, in the Q&A, and also by email or by Zoom. Thanks very much for joining us in this webinar and for your commitment to thinking about how we can center patients in TB care. Have a great day.
Thank you, Andy. I'm so glad that worked out with the recording, and we're so happy to have you here. So please, everyone, send your questions in. Our panelists are really looking for your questions. And with that, I would like to ask Jody to take the microphone from me and start sharing your screen. And you take it away, Jody. It's all yours.
Thank you very much, Petra. Just getting it going. Thank you.
Perfect.
All right.
That's great.
So I'm going to talk about the experience of client actors as a proxy for client voices. Now, this study sort of, it came out of a study using client actors or what we call standardized patients, recognizing that when someone goes to a doctor, the only thing they're looking for is not simply that they come out with the correct diagnosis. There are a whole lot of other factors that are involved. So this study, it was a sub-study that was part of a larger study utilizing patient actors. And it's intended to get at that sort of middle ground where you can diagnose a person with TB. In fact, you can test them, you can talk through it with them, you can get through the TB cascade of care. But if they don't come back to you for that diagnosis, or they don't come back to you to initiate treatment, then essentially you've lost them anyway. So what I did was I worked with a number of people that were trained up for a number of weeks to become patient actors or client actors who essentially went around to private GPs in a couple of cities in South Africa with complaining of sort of typical TB symptoms. Now, each of these actors saw a minimum of 25 physicians with the same complaint over a short span of time. And they were all from an African background, coming from low and middle income communities. And were also, for many of them, it was their very first time seeing a doctor, as in public clinics in South Africa, normally they would see a nurse for something like this. So in the South African system, when you want to pay for something, that's when you would generally see a doctor or general practitioner. So this was a good chance to kind of get a feel for how clients, typical clients with TB-like complaints might experience it. So they really became sort of a good proxy for their experience of what they thought of each of these experiences, became a good proxy for patient-centeredness or client-centeredness. So in terms of the study, what I did was, firstly, I worked from exit surveys that the actors completed upon visiting each physician. They would fill out a survey that included questions like, how would you rate this physician? Would you be willing to return to this physician? And I also did serial interviews in one of the sites with the actors on a weekly basis, looking at having them walk me through interactions where either the doctor didn't get to TB, yet they still said that they would return to them, or the doctor got at TB, but they said they wouldn't return to the doctor. So basically discordant interactions to find out what were the features that made them want to go back to a doctor that they know didn't get the correct diagnosis, or not return to someone who did. And basically what we found was that time was a huge factor. So in terms of looking at the quantitative data, for every minute that the physician spent with the patient actor or the client actor, they were 22% more likely to say that they would be willing to return to that clinician. Addressing possible comorbidities, and in the South African context, this was talking about HIV. So this, if the physician touched on HIV and started to talk about how HIV and TB could be working together, this made the client actors 3.5 times more likely to want to return to that clinician. Female providers tended to improve their willingness to return by almost a factor of 3. So that's independent of the client actor's sex. So an interesting feature that we need to look a little more into, what is it about female providers that made people more willing to return to them? And then as well, just sort of on a smaller note, those who cost more, in fact, physicians who charged more for their interactions, the clients were 2.4 times as likely to want to return to them, or the odds were 2.4 times as high. And in one of the 2 sites, speaking the language, the home language of the client actor made them more willing to want to return, independent of how they were managed for their TB. From a more qualitative perspective, respect was a big factor in whether or not someone would want to return. And the way respect was demonstrated could be as simple as shaking hands with the person when they entered the office, sitting down with them and discussing things with them, making an effort to correctly pronounce an African name made a big difference. So getting that respect made them more willing to want to return to a physician, no matter how well they manage their disease. Physical exam was a big one. So often it didn't matter how many questions they asked, but actually physically touching them made them feel like the doctor really knew what they were doing and made them more willing to return. And finally, and perhaps an obvious one, but one that often gets left out is communication. So the doctor not making decisions on behalf of the patient, but explaining to them what their options were, explaining it in ways that were accessible to the patient, encouraging the patient to respond. I'll give an example at the beginning of a serial interview. So I interviewed the same client actors every week. And at the very beginning, all the trained actors knew that they didn't need to receive any medications because they first had to be tested for TB. But because it costs money to go to a private provider, it's a very common cultural thing to expect to receive something tangible like medication in return. So even though the actors knew they didn't need to receive medications, and in fact, shouldn't have received some of the medications they were receiving, they still felt if a doctor didn't give them something, they weren't willing to return to that doctor. But after seeing how several physicians operated, later on in those serial interviews, the actors would say things like, well, this doctor actually said to me, I shouldn't be giving you medications just yet because we first need to test for TB. And I felt like they really knew what was going on. So then in those kinds of situations, they were very happy with how the provider handled them, and they were very happy to return to them. So thank you very much for your time, and just to recognize all the actors who put themselves out there, as well as the McGill University Health Centers Research Institute who funded this study. Thank you very much.
Thank you, Jody. Excellent presentation and really interesting findings. I'm now going to ask all the panelists to please turn on your cameras We are having a panel discussion, and so audience, we are looking to your questions. Shri, do you want to take it over from me for the panel discussion?
Thank you, Petra. Thanks for all the panelists for the wonderful presentation. I would take 1 minute to look at the questions coming from the participants. There is one question from Angelina. Thank you, Angelina, for this question. So just asking, are there any examples the speakers know where the quality improvement methods, for example, PDSA cycles, breakthrough series, collaborative, etc., have been used to address the patient-centered care? Do we have answers for this? It's open to any of the panelists. I would like to take this question. So she's asking about PDSA cycles, breakthrough series, collaboratives, if we have any examples.
Unfortunately, from the South African context, patient-centeredness isn't, in my experience, going into clinics and going into doctors' offices, often you'll see signs talking about the fact that the clinic is client-centered. But unfortunately, I mean, it just, in terms of scope, I haven't experienced or I don't know of any ways that are currently being done to affect change.
Thank you, Jody. So there is another question. The participant would like to know your thoughts on use of standardized patient stationery or clinical notes to promote patient-centeredness. Any of the panelists have any experience in using these notes? That would be helpful if you could share your experience.
I can take this one again because we did work with using standardized patients in the South African context, and we did. I think when we shared back the information with all of the physicians that took part, obviously people were interested in how well they did in terms of management. But the one thing that all doctors just gleaned onto was this, these findings about their practices. One thing I didn't mention in my presentation is also, the reception, how a patient is treated from beginning to end, also impacts. If their reception is very rude, or they feel like they're being treated after other patients or being ignored, really affected, no matter how well the physician did, it really affected things. So I think seeing this, we actually had physicians who said, can we hire these actors to keep coming, at random times, because we want to know how our staff is doing. We want to know how we're doing in general, not only from a physician's perspective, how the physicians are doing, but also just generally what their experience is like.
Okay, thank you, Jody. There is a follow-up question for you. Specifically, the audience asked, were there any association between the cost and the patient satisfaction in your study? If you could explain any association.
So the association that was found is that, so we went to providers who in general were in higher TB burden areas, and typically a lower cost point. So in South African Rand, up to 500 Rand, which is probably about 35 US dollars. And those that were above the median of 350 Rand, actually those that were on the higher end, patients were more willing to return to. Now this is, it's difficult to look into it deeper than this in terms of the quantitative data. So is this because they were in better areas? Is this because somehow the practice was better? But this was independent of how they were managed for their TB. So interesting that actually the higher price point and that people were more willing to return.
Okay, thank you, Jyoti. There's an excellent question from Didado. Thank you for this excellent question. It is like having healthcare workers as stakeholders for the quality improvement is really essential. It's because many clinics are overloaded with clients. Are there any practical solutions for balancing the workload and the patient-centered approach? And Andy, I would request you to take this question. I'm sure having worked with the GPs with such a high footfall, you would have some insights on this question.
Yeah, it's a great question, but I think it might. What I was trying to argue in my presentation was that this is a kind of false binary, right? That in fact, those physicians who are able to do both are by far the most successful, and high footfall doesn't mean low quality of care is necessary. Indeed, many of the physicians who had really centered patients didn't need to spend an hour with each patient, but rather were able to figure out ways to provide services and ask questions that felt meaningful to each patient. So many of the physicians that I spent time with were able to balance that workload, not by spending more time, but by integrating some of these processes that Jyoti has told us about. Touch was a big one. Asking questions that didn't seem directly medicalized were also part of the ways they made patients feel a little more comfortable. But also, knowing and spending that second to discern, is this a patient who needs more time or not? So I think that as long as we keep thinking that a patient-centered approach and workload are two opposing things, we may be able to not cover as much ground as we'd like. I would argue that patient-centered approaches don't need to necessarily be more time-consuming. They simply need to be something more, perhaps compassionate, if that's the word you want to use, or just something that's working towards understanding how patients want to be cared for and want to be treated, which is of course individual, but also broadly collective. So I would say the patient that I felt, from my perspective, which is not the physician, who gave the highest quality care, saw 150 patients a day, and that didn't really stop him from doing all these things. It was rather something that he had integrated into his practices of making time manageable and seeing patients. So I think that footfall is important and it's useful for these physicians, but they're getting that footfall by providing high quality and patient-centered care. So great question. And I think it's a really good opportunity to think about how juggling these two is actually going to help both rather than the opposite. Thank you.
Thanks, Andrew. There's a follow-up question, Judy, for this, because your study shows that communication and the clinical examination is two important elements of the care. If a doctor is not able to communicate or spend time, that may not be a good quality of care for the patient. For a provider, effectiveness is something very important than the communication. So how do you think a provider can balance that effectiveness of the treatment, the communication, which would satisfy the patient? And many of the medical schools, communication is not taught. So do you have any suggestions on this?
I think just following up on what Andy said, even though time was in there, time is not, we're not talking a really long length of time. I mean, 5 minutes, 10 minutes, vastly improved the outcome. And it's in the simple things, pronouncing someone's name or making an attempt to pronounce someone's name correctly, asking them about their family, and if whether anyone else is coughing in the family. It's not a great jump. Even being seated as opposed to standing over the patient just gives that more relaxed feeling. But I just want to note that Handa, I think, was going to talk a little bit more about that, and I think her experience is probably the greatest we can learn from in this respect.
Thank you so much, Jody, for noticing. I completely agree with Professor Andrew also on that point, that we don't need to stick to this binary narrative. Coming from a developing country context, I also know that there are real constraints when it comes to doctors, when it comes to nurses, the supply of healthcare workers. Because of stigma also it affects, because, for example, I know that at least in my context, many medical students choose not to specialize in TB because it's a stigmatized disease, and medical professionals are stigmatized by themselves, by society. So sometimes they even hide that they are TB specialists, for example, in extreme cases. So it can be really difficult for medical professionals sometimes to juggle everything. So I wanted to suggest that leveraging other opportunities, right? For example, existing community structures. So many countries rely on these structures, whether that means churches, whether that means community health workers, whether that means local officials, for example, to deliver medicines or to explain the side effects, to communicate clearly. So like leveraging these community-based structures is another important aspect. And I think that's where, as Dr. Shrey exactly mentioned, doctors tend to lack, because they are very much focused on technical aspects of things, treating patients, which is great, but at the same time, I think delegating these communication soft type of services to who can do that best. So I think that's one key thing. And another key thing is using technology, right? Nowadays, a lot of patients have phones. Of course, in less privileged areas, that can be difficult, but using SMS or using different applications to deliver reminders or to share key information, for example. So like relying on technology can also help alleviate. Just to share one example in my context, for example, patient logbooks are still not digitized, for example, and that can take hours for doctors to fill in everything and handwrite everything and things like that. So that can be digitized to save doctors' time, for example. So I think there can be a lot of complementary solutions, but I also agree with Professor Andrew's argument as well. Thank you.
Excellent, Handa. This is a very good suggestions coming in. As a follow-up, you family members have been playing a very critical role in patient-centered care, not only in getting the diagnosis done, but also in the treatment completion. What's your suggestions on how do we involve the family members in the patient-centered care? Handa?
Sorry, could you please repeat that part? My Wi-Fi was breaking it up a little bit.
So the family members are very critical, not only getting the diagnosis, but also the adherence to the long TB treatment. Though we have been talking about engaging with the family members, how do we engage these family members with the providers vis-a-vis the patient needs? Do you have any suggestions on this?
Yes, so educating family members is really key, informing them. So letting them know about this disease is stigmatized. So having that background information is really important, because oftentimes in many countries, even the word stigma is not translated, right? And there are a lot of cultural norms that are shaping people's understanding. So people are not really sure what's truth, right? What's myth, what's misconception, what's stigma, what's actually a fact. For example, TB being considered as a witchcraft on a family, a lot of people are conditioned to believe that it's actually truth. right? So there's no way for them to distinguish that. So I think it's really important to debunk those myths, misconceptions, inform family members that it's not the fault of TB patients, not the fault of family members, but it's actually a social issue, not the family members, not the patients, right? So really informing them about these myths and misconceptions can go a long way. And also helping them, encouraging them to engage in safe spaces, survivor safe spaces, or family working groups, family support groups, or care provider spaces, for example, to share their experiences. So I think that's really key, and really leveraging these survivor voices is also important. Thank you.
Thank you, Anda. There is a question on, is there any similar quality of care studies for drug-resistant tuberculosis? Does any of the panelists have any experience on this? Quality of care vis-a-vis this multi-drug resistant tuberculosis.
In our study, I don't know, Jeremiah, if you want to speak to this, because he was also part of the standardized patient study. One of our example cases was somebody who had taken previous treatment and hadn't completed it, and their symptoms came back. So you know, the data from our patient actors or client actors reflects those feelings as well. Jeremiah, I don't know if you want to add anything to that.
Yes, Jody, you're absolutely right. The data were part of that. And I may have shown a slide that also indicated the extent to which they were managed. But from the data, what we could see was that from the slide that I showed earlier, the person that had classic symptoms of TB was the one that was least ideally managed, but the other ones who indicated that they had TB kind of prompted, if I can say, better treatment from the provider. So I think that is the context that we can give this description, that if a patient presented with a history of TB, that the provider could glimpse into fairly quickly, that seemed to result in better treatment. Yeah.
Okay. Jeremiah, we also saw in your presentation that there was a GPs, and were there any difference between the private and the public providers in terms of people-centered care from your study?
Thanks, Shri. So the two studies I referred to were in two different contexts and two different time periods. One was in Malawi, involving communities, TB patients, and also providers from Malawi. And in South Africa, we were studying general practitioners. So there were some similarities. What I could pick out was, for instance, that the importance of where the patient is coming from kept coming out. The providers in South Africa were looking at all these things. They did consider all those factors. They're trying to think about how to all put together a picture of what they can say is the issue. But here is a patient. They're talking to a patient we've been talking about time issues from the other panelists, but trying to come out, you're a trained professional, and you're seeing a patient, and the patient is anxious. They want to know what's wrong with them, and they want to live with an answer. And so there seems to also be some kind of pressure on providers to juggle all these issues with the history of the patient, their symptoms, the immediate implication of the symptoms, but also the broader context. From the Malawi study, it was kind of similar, because where the patients were coming from was important in how they interpreted the actions that were being directed towards them by the providers. For instance, just the anxiety they had about being investigated and what it would mean for their role in back in their homes, for their work, for their ability to work, and for their standing in terms of their gender roles. So I think the common message that seems to come out in terms of patient-centered care for both private and public domains is that the patient is a social person, and it is critical to have an understanding of that kind of context whenever you're engaging with them. And also to add that the providers as well, as social, are human people. They are also trying to figure out how to handle a lot of information. And sometimes there is a disconnect in terms of perspective. The patient will not understand what is driving the provider, and they may feel that they are not being treated adequately or fairly. And so I think it's going to be critical to try to see how to sort of bridge that gap. But also, just going back to the earlier questions in terms of issues of staffing, low to middle income countries struggle, they grapple with staff shortages, with equipment shortages, equipment breaking down, and patients can queue for long, leave hungry, not attended, and then we could see the patients are starting to complain about possible favoritism. They feel that if drugs come in, they don't see how the drugs run out, and they are told drugs have run out. So I think that kind of context is very different from the Western context. We have patients queuing outside and struggling, and then you have a person who is a man trying to fit into this space, and already men are not supposed, they're supposed to be strong, and they are not supposed to fight for spaces with women and children. They're supposed to protect them. So I think patient-centered care will just need to look at all these dynamics and just try to put them into some kind of framework. Thank you so much.
Thank you, Jeremiah.
Thank you so much, Jeremiah. Great, excellent point. I'm just putting a pause in, Dr. Shree, because we are at the full hour, and I would like to just close the formal webinar, but that doesn't mean that we're closing officially. I would like to thank all the panelists for your excellent presentations and thoughts and messages. I would like to thank Shree for the great moderation. I would like to thank Shift TB for co-organizing this webinar. I would like to thank all the participants for your questions that you have put forward, and I'm hoping that you will stay on. We will be posting the recording. It's live already on YouTube. We will also post all the PowerPoint slides and the Q&A questions that have come up. I'm going to launch a quick poll. So we would like to have your feedback. If you could give us your feedback, that would be great. It helps us better tailor the messages. Also, for your knowledge, if you are part of the TBPPM Learning Network, all our panelists of today are. So if you have any questions, you can easily direct message them on the TBPPM Learning Network as well. The last thing I want to say is that we love your feedback. Please let us know what you think about the TBPPM Learning Network and this webinar in particular. And we're working towards a next webinar on analyzing private TB drug sales, which will be on the 30th of September. With that, I'm closing the recording of this webinar and the formal part of the webinar. Anyone who's interested to stay and ask questions or speak, I'm going to move you up towards the panel so that we can continue this discussion and have an exchange with our participants that are interested in being live part of the discussion. So with that, we close the recording, we close our YouTube live channel, and we are